Good morning, everyone, and welcome to this Global Health Unpacked seminar. This is our first online webinar. My name is Katarina Storing, and I lead the Global Health Politics Group here at the Center for Development and the Environment in Oslo. And we organize this seminar series jointly with the Center for Global Health at the University of Oslo. And our aim with this series is really to bring social, scientific, and critical perspectives to bear on the core debates in global health and to try to unpack some of the politics and interests and practices that are involved in the global health field. This morning, we are turning our attention to the politics of the COVID-19 response, and particularly to Norway's role, both nationally and internationally. We want to interrogate some of the logics and the interests and also the evidence and uncertainty that have been involved in driving the Norwegian response. And we want to look to Norway's current and future role in the global effort to curb the pandemic. This seminar concludes a one-week intensive master's course that Antoine de Benji and I have been running here at the Center for Development and the Environment, during which we've been exploring pandemics as challenges of development and of global governance. And our excellent students who come from fields like international health, development, and peace and conflict studies are going to be leading the Q&A and discussion following this morning's talk. But we will open it up for questions from the audience as well if we have time. So this morning we are honored to have with us Dr. Frode Forland, who is Specialist Director of Infectious Diseases and Global Health at the Norwegian Institute of Public Health. He is currently part of the leadership group that is coordinating the pandemic response here in Norway. And those of you who are here will recognize him from his many media appearances during these past 2 months. We have invited him because we think he's uniquely placed really to provide insights both about what's going on here, but also about what Norway's role in global health will be. Frode has experience working as a clinician, both in Norway and in Zimbabwe, and has since had an illustrious career at all levels of the public health bureaucracy here in Norway, from the local to the national level, as well as international experience work collaborating with the World Health Organization and the European Centers for Disease Control and Prevention. So we are very, very pleased that he's taken time out of what is an incredibly busy period to speak to our students and to our broader audience this morning. Please, Dr. Forland, the floor is yours.
Okay. Thank you very much, Katarina, for this kind invitation and for the kind introduction. And hello, everybody. I hope you can see me. It was nice to come to somewhere else than staying in my own flat or being at the crash, let's say, coordinating organization where we have a lot of people still working, but also at our institute, most of the people are working from home, and we're constantly sitting in media conferences or in meetings with earphones on and discussing how we can run this epidemic from our offices and from home in a global setting, which is quite challenging, both for Norway and for all countries of the world. So I was first given a kind of very loose assignment from Katarina saying, could you come to us just to speak about your experiences, just tell us something about how things go on. It's up to you. 10 minutes introduction and then ample time for questions. And then at least a couple of days ago, I got a little more precise kind of, where should I shift this? Just by clicking?
On the resume share.
Here?
At the top there, resume. The screen sharing is paused.
Here we go.
Okay,
yeah.
Go up to the...
Sorry. Oh yeah, that's fine.
See the green arrow at the top?
Yeah, I see it here.
No, the other one next to it. Yeah.
Here we go. There are always some technical challenges. Can you see my screen? Is there anybody out there answering?
Yes, it's fine.
So this was then the order that came afterwards from Anthony. How do you say it? Antoine. What underlying logics, interests, and evidence have fed into the Norwegian response? That was more serious. How have national authorities dealt with uncertainty and limited knowledge about the novel coronavirus, which I think is a very good question. And what relevance do experiences of one of the world's richest countries have for the world's poorest countries now facing their own outbreaks? I think this is a good starting point for a number of questions that we can discuss. And then the other questions that I came with myself. Next slide. Is that actually here then?
You just press the window.
The window. Here we go.
Yeah.
Yeah. Other questions that actually came to my mind when I was just starting to prepare here was about, since you are dealing with international business, how will this hit Africa? Will everybody get infected? Will we have a second wave? A lot of people have been discussing that with us. Will it change our ways of living? National versus international measures taken, and also about national versus international governance structures. And also, I've been several times in the Swedish media talking about the difference between the Norwegian response and the Swedish response. So I'll try and drop into some of these questions along my talk. And if you haven't heard any answers to them, just pick them up again when we come to the Q&A section afterwards. So just first, I wanted to stop you on this kind of general slide, which is talking about the issue of surveillance versus preparedness. And this is what we are doing every day in the public health institutes. We are trying to keep an eye on quite a high number of infectious diseases and also non-infectious diseases. We keep the surveillance systems and the registries for these infections in Norway. And we try also to make people prepared so that if something is happening, we are prepared to try and also bend the curve as fast as possible. So there is this idea of being prepared, having prevention measures even before that, and then also by surveillance being able to come in with a response at an earliest possible time during an epidemic or a pandemic, as in this case. And then when it just flares off into the blue curve here, it's an area of where you can have some opportunities of controlling the epidemic. So the window of opportunity is mostly this first phase when we see an increase in the numbers. And this is like an epidemic curve that I'll come back to, showing you just the curve of this epidemic so that we can discuss further what were the interventions taken at a different time stage. We are in normal conditions writing and keeping an eye on more like 70, 77, I think, different diseases when it comes to infectious diseases in Norway. And in Europe, they are keeping an eye on 50 diseases, on having national reporting on that system. So this is part of the ongoing preparedness and surveillance that goes on every day. And then we come to an epidemic. Then we are actually here on this pyramid of disease. Have you talked about this to them? So this is a very important figure to somehow understand. I hope you're able to see those.
It's fine.
Yeah, it goes fine?
Yeah.
Yeah. Because there is the top here, and you see the top is what we are reporting every day. How many people are dead? And this is the figures that we see internationally, and we see them in Norway. And there is this number appearing in the media every day. I personally think maybe now that we have had a too strong focus on the number of people being dead. And until now, there is slightly above 200 people who have lost their lives in Norway due to Corona. And that is since beginning of mid-March and up to now, soon mid-May, a couple of months. And during a normal influenza season, we see like 900 people dying within like normally 3 months. So then there is an excess mortality in the Norwegian society of maybe 300 per month during the winter months. So it's very difficult, I think, for people to relate to how serious is the disease compared to the people dying from other diseases. On an average day in Norway, there is like 110 people losing their lives. This is the normal of our population. And 1/3 of them are dying due to cancers, 1/3 of them are dying due to cardiac diseases or blood pressure, stroke and these diseases, and 1/3 of other diseases. And on a normal scale, the infectious diseases, they are very low in the Norwegian society. So this is like an add to that, but the numbers are not extremely high. And I think even in some of the most hard-hit countries, these numbers are not extremely high yet. And compared to other diseases, like we have that are like the epidemics of the world, TB, malaria, and HIV, we see these numbers are still low in the whole world compared to coronavirus. On a total of the whole world now, I think it's about 250,000 people who have lost their lives, according to Corona. Every year, 1.2 million lose their lives to TB. 800,000 are losing their lives to HIV, and around 500,000 are losing their lives to malaria. And this is every year. So I think it's also something we have to speak about in public, that there is a huge attention now to one epidemic, which so far has been much less serious than the ongoing TB, HIV, malaria epidemic, which we have means to stop. We know that we can actually curb those epidemics by also having good interventions, good health systems. So this is part of, I think, the message which, when it comes to comparing national and international numbers of dead people. And then what we are counting in Norway is the second under there, which are those who are in intensive care. And that's always a fraction of those who are hospitalized. And we see that maybe 50% of those who have been hospitalized have also been admitted to intensive care, and most of those in intensive care have also been given an opportunity to have assisted respiration, or being on a respirator. What is that in English?
Ventilator.
A ventilator, of course. And then we have those who have been given a positive test, taken a test and found a positive test, and those who have been in touch with a GP, and that's a high number in Norway, especially the first weeks. A lot of people went to the GP to ask, do I have corona? And then under there, we have all those people who have symptoms who never saw a GP, and below that again, those infected without symptoms, and finally those who have been exposed. And still a lot of these numbers we don't know about. You see they are red on this, and we have sources of data on the right side. We have the death registry on top there, and we have reporting on a daily basis of people to the Institute of Public Health. We have the registry for intensive care now established. We have the National Patient Registry, registering all patients coming to the hospitals. And we have the Infectious Disease Registry, which is at our institute, having based on positive tests from the labs. And then we also have a number of ways of also surveying what has been the diagnosis in primary care, called the disease pulse, sykdomspulsen, which are actually in numbers from those being having had a consultation by the GP and having their cards then remunerated from the NAV system. And then we have also established what we call a self-reporting system, which is under helsenorge.no. And what we are doing now is try to establish these prevalence studies to try and find out how many are infected actually now, and how many are infected without us knowing it, and how many have actually had the infection. And so far, it seems those first results we've had on that is that there is a very low number now in Norway, a surprisingly low number. So we had the first feedback last week on the intake of new soldiers to Norway, 1,200. And out of 1,200, there were only 2 positive tests. And then yesterday, it was announced that we had a sample of 400 people from Oslo, where they'd taken a random sample to see how many have gone through the infection. And there were only 3 positive cases. So it's actually a strong indication that the epidemic curve has been somehow flattened and going down. And it seems like this is now also reflected in the numbers we see in society. From other countries, people have been speculating that the numbers of people who have an infection without knowing it, without symptoms, might be 20 times higher than those we have registered in our databases. So still, there are huge uncertainties connected to these numbers. So this is then the epidemic curve, as you see it on the wall. And this is, I'm sure you have shown some of these curves before, haven't you? You have. No. So this is the weapon of the epidemiologist. And the interesting thing with an epidemic curve is not the cumulative number, but it's the number of new cases per day. And that is what is shown here. And you see it's like a tag, what is it, hakkete? It's like a zigzag curve. And that's, of course, because there are weekends in between here. And we don't do the same work in the weekends as we do in the weeks. So, and then you can even see the Easter is in there. And you see then there is always this kind of curve going up and then going down again during an epidemic. And during the last year, we've seen the Ebola curve actually going the whole year through, being on a kind of level that has not flattened off until just a couple of weeks or months ago, actually, for the last outbreak in the DRC. And here we can see this went fast up, and then it has gradually tapered off. And we see the numbers there from beginning of March. And those hard restrictions and measures that were taken in Norway, that was on the 12th of March. That's when we suddenly saw there is an uncontrolled spread in the society. We couldn't be able any longer to follow and trace back where did this person come from, where was he infected, and how was this infection chain being established. And that's when the government decided to take over, to say we need to have strong interventions that affects a lot of sectors. And an interesting question there is that until then, it's been the health authorities being responsible for the management of the pandemic, and then the whole government took over. And suddenly it was Erna Solberg and a number of ministers appearing every day on the press conferences. And you've seen that this has really been a whole of government approach. And compared to Sweden, it's actually very different. It's still been the health authorities leading press conferences every day. And in Norway, we are there as advisors to the government. In Sweden, they have been like the ones in charge of the press conferences, and also of the running and the management of the whole epidemic. And it's interesting to see and say this is like it's a Nordic experiment ongoing, and we will really see at the end what was the best way of doing this. So always with an epidemic curve, the most interesting things to look at is the new number of cases per day or per week, what we call the incidence, and not the prevalence. And then this is the curve over the tests we have taken. And you see the same pattern here with the Easter even more apparent in the middle there. And tests are taken during the weekdays mostly. And the number of positive tests is the black line, ending up on the right side of the scale here. So you can see we had this fast race, and we took a number of cases and a test in the beginning, and then this has also been going slowly down, and the average number of positive tests taken have been around 5%, 6%, something like that, meaning still with the test criteria we have had, being that you should have an infection, you should have a cough, you should have some symptoms, or you should be a health personnel, or you should be admitted to the hospital. Even with those strict indications, criteria for testing, we've had only 5% positive tests, meaning 95% of those coughing or having symptoms have had something else than COVID, which I think is just a reminder again. Okay, now I see I'm talking too much, and it's going fast. So I'll just draw your attention to the IHR. Has that been discussed with the group?
Yeah, but not the audience. Just
yeah. So the International Health Regulations is actually the international health law, which is the only one approved by all WHO members, which has its function in this situation. And it has the scope and the function to prevent, to control, and to also help provide response to international spread of disease without unnecessary avoiding and interfering with international traffic and trade. And I think this is like has been like a sleeping, I think, paragraph for many years until we got the Ebola outbreak. And then suddenly it was put up and everybody was saying, if we've had this working, the international health regulations with all its requirements of capacities and competences, this wouldn't have happened. This wouldn't have gone that far. And I think it's again a law that is really needed to draw attention to. And in Norway, it's the Public Health Institute, which is the national focal point of the international health regulation. And this man is the one like responsible for handling this international health regulation, and he's reporting also every day in the media about how things are going on. And there is a function in this IHR called FAKE, Public Health Event of International Concern, that he can declare. If he thinks there is a concern now for the whole world, that an international spread will be there, he can declare a public health incident of international concern. And in January, he called then what is called the emergency committee the first time on the 23rd of January, and then, or actually 22nd. And then they were saying, we don't think this is an international health emergency yet of international concern. So this is only in January. This was starting in China, and it had spread a little bit in the neighboring countries, but not around the world. But they decided the situation is with a lot of uncertainties, and we will reconvene the committee again. And what they did was to reconvene in 10 days later. And then they actually declared an international, an emergency of international concern. And then in the first statement, then he's also writing to WHO, to every country, and to the global community. He's pointing to a very important paragraph in this regulations, Article 44, which is saying that all countries are obliged to support each other when it comes to also dealing with such an epidemic, both financially, professionally, and also with building up systems so that we can try and curb epidemics in a joint way and supporting each other in that sense. And I think that's a paragraph that had also been partly the reason why our Public Health Institute has been working on global health and global health preparedness for a long while, taking this as a starting point for that. And in the beginning, we saw these pictures coming from China and coming from South Korea. So this is a meeting by the government of South Korea. I picked it then when I saw it first time because I thought it was funny, because all these people were sitting with face masks. And you know, in Norway, we had no tradition of using face masks in the public. And now we're actually doing a proper systematic review to really check out, is there any good evidence for doing that? And we've seen it's already obliged in Germany to do it in shops and in public transport. And still we are smiling a bit when we see these Chinese people coming with their face masks. And this might actually be the future also in Norway. There are some indications that it can be helpful. So this is the government sitting with their face masks in the cabinet of South Korea. And then this is actually then from just last week. Then there was a third meeting in this health emergency committee stating that this continues to be, of course, now a health emergency of international concern. And then they are issuing, again, new messages to the public. And this is what he declared, the Director General last week, and saying around preparedness, that all state parties should strengthen preparedness for health emergencies and build resilient health systems, incorporating lessons learned during different stages of the pandemic and sharing experiences with other countries. And related to surveillance, work with WHO and multi-sectoral partners to interrupt transmission by maintaining robust surveillance systems. So I think this is part of the game going on the global governance of this epidemic. And then I was asked this question about uncertainties in the decision-making process. And then I thought this is a useful slide, which I've shown a number of times. There is always, when you have an incident where you need good advice fast, there is an area of knowledge that might be gathered before, and there is a huge area of uncertainty. And when it comes to a new virus like we've had this time, there is much uncertainty on a lot of questions. And the work we have to do as a public health institute is actually to be prepared, lifting this level up so that we don't start on scratch when there is a new epidemic. We can build upon things that we have learned from other epidemics before by saying we can do also a rapid risk assessment if need be by having information from beforehand. So that's part of lifting the curve on the left side so that we are decreasing the areas of uncertainty by doing systematic reviews, by collecting all research that has been done before, by also having good research being done ourselves. And then instead of starting on scratch, we can start a little bit higher. But if you have a lot of time, like 6 months or 2 years on the right side here, you can actually increase the knowledge and you can say, we now have all the best evidence available. We've done systematic reviews, we've collated the evidence, we've judged it and produced it in scientific journals. So in this situation, when the pandemic started, we were with a lot of uncertainties, and we are now working systematically as well to try and gather evidence. And what we have been doing now at our institute is also trying to collect all the new information coming. And there are hundreds of papers coming now every day. And this map is something you can all find on the web, where we are gathering all this information, and we are trying to somehow sort the information according to the etiology, treatment, epidemiology, and so on. So you can here go in and find the evidence And this has been now widely used internationally. And also it's interesting to see also how widely used our website has been used. We had a hit of our infectious disease handbook on an average of 1 million hits per year. Previously, in March, we had 28 million hits on our website at the Public Health Institute. So it shows there is a huge interest and hunger for information during this ongoing epidemic. So this is a way of helping also academics, people from academia, to try and find the knowledge they need. And what we have been doing as well is producing what we call rapid reviews. And they are all in English. And we've done like 10 of them now. So this is just an example, one of the immunity after the infection, one around the case fatality rate, one around the role of children in spread. So these are information you can find on our website if you need more on different issues connected to the knowledge. And then we've seen also this international community coming together. And this was just from Aftenposten, our newspaper, on Monday, when they actually argued for this fundraising event that was on Tuesday, where they were trying to gather 83 billion Norwegian crowns for curbing or stopping the epidemic by getting money to vaccines development. So you might know the guys here. It's Conte from Italy, Merkel, Solberg, and France, and the two guys from EU, isn't it? Mm-hmm. Leiden, and leader of the Commission as well. Leiden, and yeah. So this was a big international, and they managed actually to get all that money in place. And what they write here, I think, in this chronicle, is very nice, and I think it's very much in line with what we have actually written now in our last risk assessment. You can have a look at that if you want, where there is also a chapter now on the international solidarity and also on human rights perspective connected to the epidemic. But what they say is that we have all in common that none of us actually can plan for or be sure for the future of this pandemic. This means that we are all part of this. None of us are immune to the pandemic, and none of us can beat it alone. We will not be safe until everyone is safe in all world cities, regions, and countries. In our interconnected world, the global health system is as strong as the weakest link. We must protect each other in order to protect ourselves. I think that's a message that actually to me is extremely important. And what I think is probably most important also to understand, to be able to prevent for a future epidemic, the best way of working is to build strong health systems where they are weakest. And of course, that's not in Norway and Sweden. It's in sub-Saharan Africa and some parts of Asia. And that's where most likely a new epidemic will occur. And the huge attention we've had to this epidemic is, of course, that it's also attacking and finding its way to the rich countries. And the slumbering, ongoing epidemics that I mentioned in the beginning, TB, AIDS, and malaria, they are still there. And they can be stopped if you had good health systems and good ways of offering services for everybody in time. So that was pulling you quickly through. I'll just pull you back then, since I started with some of these questions, if that's okay.
Yeah.
2-3 minutes. And that was, how hard will it hit Africa? I asked in the beginning. I think it won't hit Africa that hard because it's a young population. They travel less. And I think also it won't be recognized as such a big incident as it is with all those other diseases they already have. So in a way, I think the proportion of the epidemic in some of the African countries will be much less than it is in Europe. And we've heard at least some of these leaders from Sweden say that everybody will be infected. We can't stop it. It's a tsunami going around the world. I don't think that is true. So this is my opinion. We've seen no infections in the world where everybody are hit or infected. There are always ways of stopping it. And I think there are good reasons to be optimistic when it comes to the vaccine related to this epidemic. The last week, there was a message from the leader of the CEPI, the Coalition for Vaccine Development, saying that by end of the year, there might be a vaccine that can be used for risk groups. And that's making a total change in the way we can think of also preventing further spread of the epidemic. Will we have a second wave? I don't think so. I think because we've been able to stop it, we can control it by having minor bumps on the future spread of the epidemic. I think there will be flare-ups in society, in municipalities, in kindergartens, in schools, but by a very strict system now of tracing everybody, testing them, isolating, and finding a way of follow-up each and every case, I don't think we will have a new big wave. That's also built on the theory from other pandemics where there was no effective interventions. Also, a vaccine will, of course, make it less likely that we'll have a big second wave. If we open up again fully and don't have restrictions that work, we will have a second wave. But we've seen that all those restrictions or measures that we have taken, they have worked. So I don't think we will have a second wave, but we will have small waves then, but not a big one. And I think it will change our ways of living. I think it will have an influence in the way we are thinking of traveling internationally. I think it will somehow be a game changer for the cruise traffic. I don't think a lot of people would like to sit on those ships any longer. We see there is a vulnerability of being extremely closely together. I think it will have to be also a reminder of the way we are living with the ecosystems, somehow always intruding into the habitats of animals, and with also living with animals in a very unhealthy way in parts of the world, and also destroying the ecological balance of nature. Yeah, the national versus the international measures, I don't think this can also be kind of stopped within the borders of a national state. And we've seen extremely many, or I would call them almost nationalistic ways of trying to deal with this, instead of having a globalized way of thinking through how we can stop this in a joint way. And I think the EU, they are pretty frustrated not having a opportunity to try and govern and run the European countries together in this sense. And finally, about the Swedish-Norwegian approach, I think so far it's difficult to say what would be best at the end, but I think it has been a high price for Sweden, the costs of going through this, what they think will be a herd immunity, and saying that's what we have to sacrifice in the beginning to have a good result at the end. I think the Norwegian approach has been more on what you say, føre var in English, precautionary, having taken a precautionary principle of having strict interventions now, and we are now lifting them. So today we are more or less on the same level as Sweden when it comes to how the interventions are ruled out in the society. So that was much more than 15 minutes, but I think I'll stop now and then we can have time for questions.
Okay. Thank you very much, Frode, for taking us through such an interesting talk, and also for highlighting the role of strong health systems and of international solidarity as the basis for dealing not just with this epidemic, but also the other ones that we see across the world, and for future preparedness efforts. And also thank you for ending on an optimistic note. That was nice. So we're going to now turn to some of our students who have some questions that they would like to ask you. We're going to start with Lars Henning Wenke. Please, Lars Henning, you can ask your question. And feel free to turn your video on so we can see you.
Yes, good morning. I see I'm not able to turn on my video. Let me try. I don't have the rights for that, but I'll ask my question anyway.
That's fine.
So thanks for some fascinating insights. In this course, we have learned that a pandemic is in many ways profoundly connected to longer-term social, economic, and political imbalances, domestically as well as globally. Yet in the public discourse, the COVID-19 pandemic is typically portrayed as a spontaneous short-term event. With experts such as yourself currently commanding a lot of attention in the public eye, in what ways can experts direct public attention towards the connection of the COVID-19 outbreak to these underlying long-term problems?
Well, I was partly touching that when it comes to the ecological ways of living in the world. I think that's part of this game. But and we always see that pandemics, they hit hardest to the weakest and most vulnerable part of the population. But at the same time, I think there is something here with this epidemic that is also a bit different from other epidemics. It's been hitting the industrial part of the world hardest. And I think also it hit the old old part of the population hardest, which is a bit different from at least influenza pandemics. So it's like I've sometimes described it. This is the epidemics going from a ski resort to the old people's nursing homes. And it's been brought to Norway by the strong and rich people out being on their winter holidays, and brought back to a society where some other new vulnerable groups are being affected, those with underlying diseases and those who are the elderly of the society. And I think there is always a gradient also when it comes to something related to epidemics. And the causes of the epidemics is, as you say, connected to the underlying societal structures. But in this event, I think also there is an all of societal approach that has to be taken to be able to curb it. And it's not so evident at this stage, but we will analyze this at the end and see how can we also understand the social inequities when it comes to both treatment and being exposed to the pandemic. So.
Thank you, Frode. We're now going to turn to Annabelle Fiemempel, who's going to ask a question.
Yeah. Hi, I'm also not able to turn on my video, so I don't know if there has to be some rights from the host for that. But thank you so much for your interesting insights. And my question is, in your opinion, what's the role of international organizations, specifically the United Nations, for monitoring compliance with international human rights and holding other national governments accountable, for example, for spreading false information or prioritizing multinational companies over the health of their own citizens? So this relates, for example, to the right for health information or the right to adequate living conditions. And of course, while the UN must honor sovereignty, it doesn't really adequately call out other countries for breaking international agreements.
It's a big question. And of course, I think the role of WHO is totally fundamental and crucial in leading like the world response here. I think some of the worst things we've seen during this pandemic is the US somehow cutting off their funds to the WHO because they were a bit too positive about the numbers and figures from China. And there is always this idea of blaming somebody. And I think the WHO has done a good role. They have sent missions to a number of countries during the ongoing pandemic to understand the situation and also to ask for support for other countries. And I think there is a role also in both multilateral organizations like the EU and WHO to try and avoid unnecessary interference with the borders and the travel and trade restrictions. And that has been now applauded everywhere, that you can close the borders. So the only country of the Nordic ones that is not closing the borders is Sweden. And I think there is a lot of things here that is not very helpful. And as you probably have talked about when it comes to the Ebola pandemic, there was a huge economic downturn due to just closing those borders and making restrictions on travel and trade. And also we see that there is a role of the WHO and others to try and have a equal and fair distribution of vaccines and drugs that come up. And we've just started a group now working on the prioritization of vaccines. And we see that a number of multilateral companies are now working on the vaccines, and other countries are working with those companies to try and restrict the vaccines to their own population. And I think we really need an international view on that and find ways of working with international solidarity to have a fair distribution of vaccines when they come.
Thank you very much, Frode. I think that is a nice bridge to a question that I know Teresa wants to ask about the role of public-private partnerships in vaccines. Teresa, please.
Hi, thank you for being with us today. It's very interesting to hear you talk about this in real terms. My question is a bit related to what you mentioned before. You mentioned CEPI. What is Norway's public health policy position when it comes to public-private partnerships for research and development of vaccines and other pharmaceuticals, both during the pandemic and in general? Do you think that public-private partnerships can improve equitable and fair access to vaccines and other medicines again during pandemics, but also as a global health strategy? Thank you.
Yeah, this is a very popular term, in global health, and in Norway we are not using it that much, but there is a kind of sharing of work, and in Norway we don't produce vaccines any longer. We did that at our institute until the 1980s, 90s actually, and we've had some minor things going on as well until recently when it comes to testing vaccines. But now we've seen that this is a very specialized way, and you need extremely specialized factories to do that. So the organization of the vaccine development in the world is done by the companies. And I think there are like 12 vaccine candidates, and they are all driven by private companies, but they have to be governed and steered, I think, very much strictly also by public interest. Otherwise, they will just have this interest of being developed for the profit of the owner. And I think when it comes to diseases that are not having any market, before suddenly there is a huge market for this disease, then you need to have other ways of investing in how you can also deal with health issues. So, the CEPI, they are working on vaccines for Nipah, for Lassa, and for MERS. And few people knew actually anything about those diseases. And they have been partly involved in the Ebola trial. And now suddenly they have taken a leading role in also developing vaccines for the COVID-19, because they could also build on the experiences from the SARS epidemic and from the future development of the MERS vaccine. So I think there is a role for public-private partnerships, and I think we have to explore also ways of doing that maybe more in Norway. But so far there is this strong public health system in Norway that is not really requiring that much interventions from the private sector when it comes to the normal health services. But when it comes to the production of vaccines, I think it's extremely useful.
Thank you. And you think that they can help ensure equitable access?
Well, I think there are other means of securing equitable access than actually using the public-private partnership model. I think that model is more for other purposes than actually the equitable access.
Mm.
Yeah.
Okay, well, thank you very much. We're going to pass on to Johan Marius Lerøy. Johan, please ask your question.
Hi, thanks so much for taking some time for us here today. It's been really, it's been great to get an illuminating and current take on the situation. So my question to you, it plays a bit onwards on the answers you already given, but it'd be interesting to hear more. So as you've mentioned, pandemics like this call for global collaboration. Mm. However, with global collaboration also comes a responsibility, I believe, to inclusive and equitable policy solutions. Arguably also, the same virus might require different measures in different contexts, and there are few, if any at all, magic bullet solutions. So my question is, how do we practically ensure that the global response to COVID is not solely predicated upon the wishes of the biggest donors or the largest pharmaceutical companies and so on? And how might we be able to take into account the needs, experiences, and not the least the livelihoods, the economic livelihoods of communities in the global south?
Mm. Yeah, I think you are fully right that this pandemic needs different approaches in different settings, and I think what we've seen in South Africa now is an example that they have imposed huge restrictions to like I've just seen pictures and read reports from Cape Town, probably all over the big cities of South Africa, which is probably helping maybe some of the well-off middle class and upper class people and causing extreme burdens on the poor. And there is no opportunities, I think, when you don't have running water, when you don't have shelter where you can stay far apart, where you have to sit together in one room or live together in one room, and you are not allowed to go to work, you're not allowed to travel, then you are just making the burden of the poor even worse. So I think those restrictions that we have imposed in Norway, they are not feasible to use in a setting in very many African countries. when you have a country like Malawi where there are like a handful of ventilators for the whole country, you cannot think the same way as you can do in Norway, where suddenly you can increase this number and you can make reorganize the hospitals to be able to cope for so many patients at the same time. So I think the health system in the bottom and the economic situation of the country, the labor market, the ways people live will extremely much have to govern the way they should also make interventions. What we've seen also now in Africa is that they have developed test capacity for testing for COVID, but they are not able to buy the tests. They are all bought and taken by other countries up north. So there are huge challenges also finding a kind of equal way of doing this. And I don't think one size fits all here. So I think it's really important as well to discuss how can this be done in a decent and a most cost-effective way, those interventions that are needed in low and middle-income countries.
Thank you very much, Frode. Thank you to the students for your question. We're now going to open up to a broader audience, and the first person on the list is Christoph Gladman from the University of Oslo. Please, Christoph.
Yes, thank you for having me on board here. Thank you, Frode, for a very, very interesting presentation. I'm Christoph Gladman from Center for Global Health and Helsam. My question is a bit about the geopolitics of global health. One thing I think we're seeing in the current outbreak is that a country like the United States, that has been very much in the forefront of spreading global health, of very often also telling other countries on how to handle their own outbreaks. We think of the Ebola crisis. That country is now badly hit by COVID at home, while other parts of the globe are delivering more inspiring examples. So my question is, what is this going to do? What is the COVID crisis going to do to the geopolitics of global health? Is there a danger that WHO ends up paralyzed between the United States and China?
Yeah, well, I think there are somebody on the other side of this big sea that are always trying to find somebody to blame. And it feels like people are also using this opportunity to create a geopolitical tension between countries. And I think it's very interesting to see how much more efficiently China was able to curb the epidemic in their country than the US is for the time being. Russia somewhere in between now. We have not really yet seen what will be the outcome of Russia. But I think China, South Korea, Singapore, and Japan has somehow shown to Europe that it's possible to do this by strong societal social distancing measures. And that is, of course, the model that has been advocated by WHO. And then suddenly also WHO has been charged by the US as being on the side of China. And I think more than anything else that this pandemic is a test to the health systems of countries. And this is not just a public health system. It's about also having good systems for treating patients. It's for diagnosing, treating, and finding a way of dealing with it also at a community level. And I think also in Europe, we see extreme changes and differences between even like France and Germany, between Germany and UK. And we see that in Germany, it seems they've been more prepared and are on the level of Norway when it comes to this stage of the epidemic, when it comes to number of deaths. And in the UK, they were a bit late. And if you come late, then you have suddenly a widespread in the society before they had their interventions. Sweden gradually increased their interventions. And also we see they have now a 6-7-fold numbers of dead people compared to Norway, which is a huge number, I think, between just very, very equal countries. But they think in the long term, that this will be the better solution. So I think it definitely affects the way of thinking forward. I think also when it comes to leadership of global health, Germany is taking on that position and definitely taking over the role that the US have had before. And probably together with France, and also actually the EU is jumping in and having a step up when it comes to being a leader in global health governance.
Thank you very much, Frode. We have a question that's come in writing here from Silas Mashambere. He says, you rightly put a light on the disproportionate response to COVID-19 and other infectious diseases that are killing millions of people every year, like tuberculosis, malaria, and HIV, which are affecting mainly the poor countries. The question is, do you think Norway and other rich countries will consider this reality seriously of ending these preventable and curable diseases, or is it likely that the solidarity that we've spoken about will end with COVID-19 and will only come back again when rich countries are affected?
Yeah, that's a crucial question. I think I've been really thinking of this for a long while, and I think what has been done is also, when it comes to Norwegian initiatives in global health, they've been very much supporting, for instance, the Global Fund. And the Global Fund is, to try and combat TB, malaria, and HIV. And that has been, I think, pretty successful. At the same time, they've forgotten that to be able to do that, you need a proper health system at the bottom. You need to have also a system that can care for all other diseases. So I think what we need more than anything else is also a kind of a global initiative to say we need to strengthen health systems. WHO is working on that. And I think also the IHR, the International Health Regulation, is a way forward to say we have a regulation stating what all countries should have in place. And there has been done what is called the joint external evaluations of these health systems in more than 110 countries now, all showing there are huge kind of discrepancies in what has been, what competences and capacities are in place compared to what was meant to be there. And I think that's a good starting point also for saying there is a need for an international move to really lift the health systems of all countries, not only trying to be stopping one epidemic, but having a way of treating all diseases and also future epidemics. Thanks.
Thank you very much. And the next person on my list is Candela Iglesias Chiesa. I'm going to allow you to talk. Please ask your question.
Hi everyone. Hi Frode for a great talk. My name is Candela Iglesias. I work as a consultant in global health here based in Oslo. And I think my question is a little bit more around the rapid reviews that you were talking at a certain point. Would you be able to tell us a little bit more about the results, particularly on the rapid review on protective immunity against SARS-CoV-2?
Yeah, that's we've done that once and we've updated it once because we see the information coming is extremely fast. And then that's, you've heard WHO saying we cannot be sure that there will be immunity. And we've heard people being very optimistic when it comes to developing of a vaccine. In this specific situation, the immunity that we have looked at in that review is about antibodies. And it's not about cellular immunity, which might also play an important role. And we see in COVID-19 that there are issues related to a overactive immune response leading to the pneumonia that people are getting. We see that they produce antibodies in the mucous membranes of the throat. We see there is an EGM response, and we see there is an EGG response, which is the more long-term response. But we don't know yet the protective value of the immunity that is created, how long it would last, and in what kind of ways it can actually lead to what this herd immunity as a term. So still, the answer is that there is still a lot of uncertainties when it comes to long-lasting immunity for COVID-19. But you'll find the report on our website. It's not saying everything, and it's also partly written about this in the last risk assessment we did. Thank you for the question.
Thank you very much. I'm now going to turn to a question from one of the audience. It's from Austin Davis, who's at NORAD, who is wondering, how do you think that the vaccine development should actually be financed? Should it come from the aid budget? Is it aid?
We cannot say that it's aid when it's mainly to be used, I think, also in the richest part of the world. But it's the way of financing CEPI, I think, is fine to use with the aid money, because CEPI, with the diseases it has been designed for, has been diseases of neglected tropical diseases and diseases that we are not really able to do with money from commercial interests. Now there are huge commercial interests, of course, in also finding ways of stopping the COVID-19. So in that sense, I think this is not development work primarily. This is stopping an epidemic because of the devastating economic consequences it has to the Western world, to all countries of the world. So in that sense, I think it's global solidarity, but it will benefit the rich world even more than the poor part of the world. So I think it's a way they've been able to pull out money, and I don't know from what budgets they came, but I think it's a good discussion, Austin. Thank you.
Okay, thank you. Maybe can I take the privilege of asking you a question as well? One of the things that we've been discussing in this course is the emphasis that's placed on health technologies and vaccines, technological solutions to health, and also new digital technologies to health. Yesterday, we spoke a lot about this and the role that, for example, mobile phone data plays in tracing the pandemic, and the role that contact tracing apps like the Smittestopp app that was recently launched by the Public Health Institute. How important do you think these new technologies like the contact tracing apps will actually be in managing the pandemic globally?
Well, this is not on TV. I think it will have a supplementary role, and we are for the time being testing it, and we are getting a lot of let's say challenges by finding ways of making it useful. But I think it will help being on this stage of the next year where we have to do this very active testing and tracing activity, and sometimes you don't remember who you met. But I've said a number of times, I think the proposal from the ordfører, the mayor of Nordkapp, he was saying, I made a small book, which I always keep in my pocket, and I'm writing down the name of the people I always meet every day now. So it's actually yourself being responsible for knowing who you met. But of course, you cannot do that always on a bus or on a whatever setting you are in. So if you are able to avoid being too close to 2 meters for 15 minutes, you don't have a problem. But of course, that is the advice we've given. A number of people won't know who they met always, and then this can help. But the most work of the tracing will still be done by the people in the municipality. And this can help them doing this to a little bit further extent.
And do you think it'll open up for create for further digital surveillance of society under the name of public health?
That might be, that it actually can be very useful as a research project to see also how, because we can see patterns of movement. It's not only to see who you met, but you can see also a lot of other information. And also in the models we are making to try and produce this much spoken about, the reproduction number, is also getting data from Telenor already to see how people are moving. We see who are susceptible, who are exposed, who are infected, and who have recovered. And we compare that also with the movement of people and the numbers in hospital and in intensive care. So that's the reason, or the background data for the development of the R.
Thank you very much. Okay, I'm going to pass over to my colleague Antoine here, who has the final question of today. And I know that there are other questions in the Q&A. Many of them have to do with this juncture between interventions in the global north and the global south, and how to deal with those imbalances. But we've touched on some of that. So I pass over to Antoine for the last question.
Yeah, it feeds to what you were just saying and talking about, and there is a question relating to the role of models. You talked a little bit that they help to lower uncertainty. That you talked that they draw from mobile phone data and etc. But how exactly influential have these models be in the Norwegian response to COVID? In the UK, we saw that the SAGE group, which advises the government, almost a third of its members are mathematical modelers. How is it in Norway?
I think it's an important question, and I think I think they have been given too much weight, and I think it's to me a bit scary. You have a lot of information, you put it into a huge equation, and you come out with some formulas that nobody understands, and at the end there is a number coming out which is governing the response. And I think we have stressed, and a number of us people working in global health and in public health, we are more like professional people, not mathematicians. I can say the same as the models say. Give me the data and I can draw the line. I can see it from what I see. I don't know to hide it in a lot of mathematical modeling. And I think also it's been like a quick fix in a way. Give us the R and we can tell you who you are. and how the epidemic develops. And I think we should definitely be cautious about how much weight we put into it. And it's now also, we don't know a lot of things. And we see we are using the same R in Norway and Sweden, in a way, the same way of calculating it, but the strategies are totally different. And there will always have to be a lot of human knowledge and input and understanding to be able to find the best way out of this.
Thank you very much, Frode. We really want to thank you very much for joining us this morning and really helping to demystify some of the role of mathematical models and technology, but also for showing us these important links between responding to emergencies and building up more long-term health systems and structures, and also the important links that exist between national response and global solidarity. Thank you to all our students for an excellent effort this week and for posing good questions, and for our other attendees for their questions too. We will be making this seminar available as a recording after the event. And we hope to be able to welcome you to more around the table seminars in the future. But for now, thank you for joining us for our first Global Health Unpacked webinar.